Good Monteggia.
Thank you. That was an excellent lecture. It goes through the basics. What I wanted to do is to see what real time was about and what had really happened to patients who had been operated by the various techniques. So I set aside to do a review of some of the cases that had been done in children's. I feel that the character of the ulnar fracture is the most important aspect of the management of this rather than the direction of the radial head, because once the ulnar is aligned and corrected, they pretty much will resolve. Reduction occurs, or better still, the loss occurs in 20% of those that are not stabilized. So I would say two things. One has to be able to reduce the ulnar, but also to stabilize it in that position. Stabilize non-displaced green sticks. It's very important because there's a possibility of failure. And I feel that you can use an implant, especially for the ulnar, and to leverage or to joystick it to get the anatomic reduction. And for whatever reasons, in most cases, the radial head will pop in. So what we're going to do is that we're going to take a look at some cases, see what was done and how it worked. Here you have pretty much all of the bad things, including the radial neck. Radial neck fractures are so much associated with this. Until this review, I hadn't appreciated that in the practice. But anyway, with this, and we've got several methods of treatment, but this will include all of them, which will be internal fixation, reduction, open reduction, and possibly osteotomies. As we look at it, we see that once the ulna is aligned, it can be used with a Steinmann pin. And so the reduction here is an open reduction and internal fixation with the Steinmann pin. Another where there is almost like a buckling fracture of the ulnar, one sees that it's raised. So why not fix the ulnar? So simply repairing the ulnar in terms of manipulation and control, one can see that you can get an anatomic reduction. So this is a correction, reduction, and cast control. In this one, it's a long oblique fracture of the ulnar. If you can stabilize the ulnar, more often than not, the radius will come into line, such as what has happened here, so it can be done very easy. Again, I would want to pay more attention to the ulnar than the radial head. You know it's displaced. Another type of buckling, this has its own osteotomy. Take advantage of that. A Steinmann pin, a rush rod can be placed in, aligned properly, and to get in this particular patient, you can get an alignment and it stays and it's comfortably good. So this is an open reduction, an internal fixation with K-wires. Another with an angulated on the same principle. Place an implant, whatever your implant of choice is. A rush rod is possibly the best that we've used to be able to put it into line, arrange it, and this is the result that you'll get with it. So this is closed reduction, joysticking with a rush rod. Another type of injury, the same type, except for another situation that I saw to occur, and that is radial neck fractures. I hadn't been aware of that. This is a radial neck head fracture. Look that it's displaced. It was appreciated that one could do it with a rush rod, except it didn't work. So make sure you get an x-ray. So this had to be remanipulated because look, the line that goes into the capitellum is not there. It was redone, replaced. We can see that there's an osteotomy there. And with this, we see that there is an excellent result with it. Again, take a look at the radial head, which was very compliant and responded to the treatment. This is a completely displaced one. You have the same principles, except when you see this x-ray, you know that the individual needs a friend. Every pediatric orthopedist needs a friend, someone that they can consult with, someone that they can discuss cases and talk to. The worst thing to do is to undertake a procedure when you don't really have a lot of the confidence that you could do it. So whenever I see 3 pins trying to hold the radius to the ulna, there's a problem with that, and this one is not going to be good. Because one, it was a very long case, it was open. Take a look at it because the goal and the objective was to get the radius to line up with the capitellum, and it didn't work. And there's arthrosis in this particular child already. So you shouldn't probably tackle a case like this without a friend if you've not done a series of them. So call a friend if there's a question. It's very important. Rarely do you see the posteriors. In the series that I looked at, it was a small series, but I saw only one. This is a posterior displaced Monteggia, and it was not treated. This was a historical piece. that was not treated, and I looked at it, but the patient had been back, and had been back for some arthrosis, and one can see that this has gone to full development, and one can see that the radial head has remained posterior in this particular case. So when we look at this, what can we get out of it? One, if you're going to do a chronic, there's a belt palsy. If you've not done a belt palsy, now in the generations now you have, I guess there's YouTube, there's videos, there's something for everybody to do a procedure, to watch a procedure to do, but that should be done. In the literature, there's a term that really at this stage of my life really gives me a lot of problems, and that is a transcapitalar radial pinning. I don't know how many people still do that. If you're going to do that, make sure that as soon as possible, perhaps the minute you put it in, you should take it out. Seriously, though, it is not good. And there are anchors. There's so many ways to stabilize it today. This is a patient who had an excellent operation. One can see that the radius has been brought out. The aponeurosis of the triceps for the annular repair has been done. It's just beautiful. And this is, at the end, it's just wonderful. This is a problem. And if you're going to do this, and I would recommend against doing it. You've seen this one that I'm showing today. Perhaps that's enough, hopefully. Because once you see this, this patient has to be carefully monitored and watched. Because if they don't come back, or if there's a problem with it, then all kinds of bad things can happen to the radiocapitellar joint. The thing that I didn't realize in undertaking this is the number of radial neck and radial head fractures that were associated with Monteggia's and what ultimately happened to them. A lot of them did well, but they didn't all resolve. Take a look at this. You can see that there's remodeling that's occurring. The patient is asymptomatic, but this is a problem and will continue to be a problem. What else do we think about? When we think about the radial head, we think about what's congenital and what's acute. It's been stated that not congenital, but maybe a deformity from birth process would be that the head, rather than having the cone shape, would have a prominence. However, this is not completely true. I've seen patients with hereditary exostosis that have started out located and then subsequently dislocated, and the head hasn't been compressed, and it's been found to be that way. This is an acute process. I don't really think you need to go to an MR, but it gives us something to teach, and that's what we're here for. Rambo, we've heard lots of things. We've heard trash, we've heard all of those things, but I think Rambo is important. Take Rambo with you, and with every x-ray you see of the elbow, think of Rambo. And Rambo is radial articulations missed by orthopedic surgeons. And if you do that, you'll never miss one of these because it can be subtle, but Rambo is important. So, techniques. We saw all the techniques. Closed reduction of the ulnar fracture, relocation of head dislocation. Closed reduction, never transcapitalar radial pin. Closed reduction, ulnar and annular ligament repair. That is good. Talk to a sports medicine doctor who can talk to you about anchors to put in, and you can repair the annulus and make the triceps work. Open reduction of the radius and IM implant. That is what I'm recommending. Regardless whether it's bowed, whether it's plastic, whether it's a green stick, if you can stabilize the ulna, you'll maintain your reduction. And then open reduction of the ulna, relocation of the radial head, and cross-pin fixation. Pinning with fail reduction, that is not a thing. That means if you can't, at the end of your operation, get this to stay in through pronation, supination, then you've not done the work that you need. Again, as I said before, find a friend, call a friend, ask a friend. Don't let the child pay that much for your education. So again, reinforcing character of the ulnar fracture rather than the direction of the radial head dislocation is most important. The radial head fracture, I was not aware of it. Look at it. It's amazing what you can see by looking. And remember, the pathology is always looking at you. The question is to whether you see it. Ulnar bowing, green stick, plastic, make sure that you can straighten it. Reduction loss occurs in 20% with oblique non-stabilized ulnar fractures. Stabilize the non-displaced green stick ulnar fracture. Stabilize the ulnar fracture always, and use an IM implant to leverage reduction. You can get your green stick. And then late reconstruction is unpredictable. Thank you for your